So 5-FU and tamoxifen, both widely used anti-cancer drugs. Yet, while 5-FU-DPYD is implemented in clinical practice and successfully implemented, the tamoxifen C2D6 is not adapted the same way. Why is that? Is it because toxicity-related signals are generally more straightforward to act on compared to those related to efficacy?
So if you look at the data that's out there for all drugs in terms of pharmacogenomics of drug efficacy and drug safety, the pharmacogenomics drug safety has been more successful than the pharmacogenomics of drug efficacy. And there are many reasons for that. Efficacy is much more difficult sometimes to define, and the evidence you need and the type of evidence you need, including different types of trials, can be quite difficult to perform. And when you're looking at an efficacy parameter, it may be long-term. So, for example, with tamoxifen, the issue is that you are looking at recurrence of breast cancer, and you may need a follow-up of 5 to 7 years before you can get enough numbers of people who developed recurrence and so on. So most of the data that's out there at the moment on tamoxifen is observational data, where people have followed cohorts through and highlighted that the risk of recurrence in people who have different polymorphisms in cytochrome P452D6. The data overall is highlighting that it is important to do genotyping of cytochrome P452D6 when patients go on tamoxifen and use alternative drugs if you can't metabolize tamoxifen appropriately, because you get lower levels of endoxifen, which is active metabolite. However, there are differing views out there amongst the oncology community, and there's still quite a lot of debate within the oncology community whether this is worthwhile doing. In certain parts of the states, this is now routine practice. But in Europe at the moment and in the UK, this is not routine practice. If you compare that to DPYD, where you have a serious adverse event, and the adverse events are bone marrow depression, which leads to neutropenia, leads to sepsis, which leads to ICU admission. You have serious diarrhea occurring and patients ending up in hospital dehydrated, or stomatitis that is so bad that they can't swallow any food. These are really hard endpoints and serious adverse events. And it is perhaps easier to understand that if you have these adverse events and so on, and you've been able to see them soon after the drug is given, usually within a couple of weeks of giving the drug, then it's easy to see the temporal relationship and do something about preventing that and so on. So I think that is that has been shown overall with safety events as well as efficacy events, and it has been easier because of that to implement safety events.